Good afternoon, everyone. Welcome to virtual grand rounds for the Department of Medicine. Today we have two faculty members joining us, Dr. Kalyan Bhamidimarri and Dr. Ozlem, and it is my pleasure to introduce them today. We will start with the clinical vignette on COVID-19 and liver dysfunction presented by Dr. Bhamidimarri. Dr. Bhamidimarri is an associate professor of medicine and chief of hepatology. He completed his residency at the Bronx Lebanon Hospital Center, followed by GI fellowship, as well as hepatology and transplant fellowships at Mount Sinai School of Medicine. His research interests include NASH cirrhosis, viral hepatitis, and outcomes after liver transplant. Thank you so much for joining us, Dr. Bhamidimarri. I'll pass it over to you for your presentation.
Okay. Thank you all for the kind introduction. Are everyone seeing the screen that I'm sharing?
Yes, just put it in presentation mode. Yep.
Okay. All right, so good afternoon. Thank you for inviting me to the medical grand rounds. So today I'm going to talk about a case that we consulted on about a month ago in a patient who was tested positive for COVID. And after the lecture, we should be able to figure out whether COVID-19 in this patient was a culprit or bystander for her liver dysfunction. So this was a 30-year-old Haitian woman who presented with abdominal pain and vomiting. She was first hospitalized at an outside hospital. She complained of subjective fever, malaise, abdominal pain, and diarrhea for 7 days. Interestingly, she didn't have any cough, shortness of breath, or upper respiratory symptoms at the time. The hospital records indicated that she didn't have any respiratory distress. However, she was profoundly icteric. She had abdominal tenderness, acute kidney injury, non-anion gap metabolic acidosis, likely from the diarrhea, pancytopenia. She was admitted to their ICU and was started on empiric broad-spectrum antibiotics. And given the presentation MEL score of 36, which was acute, she was referred for transfer to Jackson Memorial for transplant evaluation. The patient came to Jackson Memorial within a day, and her admission diagnosis was acute liver failure. She was lethargic and afebrile on admission. She did complain of generalized abdominal pain. There was no focal point. She did have jaundice. She complained of profound nausea and intermittent vomiting. She didn't have any confusion up until that time. And on review of her past history, she did have a hospitalization for alcoholic liver disease in 2018. She wasn't sure if it was alcoholic hepatitis or cirrhosis at the time. She didn't have any past surgeries. Social history did include binge alcoholism. She used to consume several shots of liquor every day up until the time of admission. She didn't smoke or use any drugs. She was single, lived alone and independently. She didn't have any kids. Her family history, parents and brother who lived close by were healthy, but we could not obtain more information about their family. So on admission, she was mildly tachycardic. This was sinus tachycardia noted, heart rate of 122. She was hemodynamically stable, respiratory rate of 21. Temperature was normal, and oxygen saturation of 100% on room air. Physical exam showed that she was not in any kind of acute distress. She was talking pleasantly and answering all the questions. However, on the rest of the physical exam, you can see that she was profoundly icteric. Heart sounds were normal. There were decreased breath sounds on the right side. Abdomen was soft, mildly distended. There was generalized tenderness, but no guarding or rigidity. She was alert times 3, no asterixis or altered mental status. So on the lab data during the admission, we can see that the patient is profoundly pancytopenic. WBC hemoglobin and platelets were very low. She had a sodium of 129, creatinine of 2.9, alkaline phosphatase was 116, AST of 765, ALT of 151, total bilirubin 12, INR 1.8. Tylenol and ethanol levels were undetectable. And given this picture, she did have a MADRS discriminant score of 50, and anything over 32 indicates that this is severe acute alcoholic hepatitis. She did have a MEL score of 36, and given the acute kidney injury, she has ACLF grade 1. The scans from the outside hospital, the chest x-ray showed an interstitial infiltrate at the right lower lobe, but no consolidation or effusion. She did have a CT abdomen without contrast, and given the acute kidney injury, which showed that there was moderate ascites, but liver and spleen were normal. There was no biliary dilation, and kidneys were also normal in size. At Jackson, I will show you the chest x-rays. There were no acute abnormalities initially, and she had an ultrasound of the liver with Doppler, which showed coarse liver, but bile ducts were okay, and the vessels were okay. She did have small amount of ascites and mild right pleural effusion. So according to the current scenario, this patient has ACLF, disease acute on chronic liver failure, which according to the definition by EASL and AASLD, any deterioration in a pre-existing chronic liver disease would qualify as ACLF. It's typically related to a precipitating event, and it is characterized by the presence of organ failure. And it is because of that organ failure that there is an increased mortality at 3 months. A couple of things we need to know about ACLF is cirrhosis need not be present. Any patient with chronic liver disease can be at risk. The second point is any injury to the liver, which can be a systemic insult like sepsis or SIRS, can also cause ACLF, and we need to keep that in mind as we evaluate these patients. So again, depending on the underlying state of the liver, whether it is chronic liver disease, compensated cirrhosis, or decompensated cirrhosis, the ACLF can be divided into 3 types, type A, B, and C. And again, it is characterized by not just hepatic failure, but also extra organ failure. Some of the precipitants that we actually look for in a patient with ACLF are listed here: the viruses, drugs, alcohol, ischemia, post-surgery decompensation, sepsis. Sometimes it can be idiopathic. And in the current setting of the pandemic, again, COVID-19, which causes a severe cytokine storm, could be one of the initiating factors for ACLF. So again, we need to work up for all these precipitating factors. Now, the pathophysiology of ACLF is a vicious cycle which starts with hepatocyte cell death. So again, here you can see that the balance between hepatocyte death and regeneration is lost. So there is impaired regeneration, which actually causes this systemic inflammatory response syndrome that results in organ failure and toxin accumulation. And this cycle perpetuates, worsening the ACLF and the grades of ACLF, leading to poor outcomes. Now, back to our patient. On day 1, she was admitted in SICU, and nephro and hepatology consults were called. She was started on a bicarb drip for metabolic acidosis. And on day 1, she started having cough, and she did have an oxygen saturation that went down to 69% on room air. So since she was a PUI, she was intubated with a rule-out COVID. And at this time, her heart rate and blood pressure were stable, and given the AKI, she was started on CBBH. On day 2, she actually worsened even more, and she started becoming hypertensive. She was started on 2 pressors. Again, she was intubated already. The initial viral hepatitis workup came back negative, but interestingly, she was positive for HIV, which was a new diagnosis, with an RNA of over 180,000, and her absolute CD4 count was 8. Now, the first SARS-CoV-2 test was negative, and at this time, given the 2 pressors and hypertension and AKI, she actually qualifies to be ACLF grade 2. Now, like Dr. Shafazand mentioned in the previous grand rounds, that our focus is on COVID-19, but there can be other viruses that can cause influenza-like illnesses. So again, she had a respiratory panel that was checked, and the only thing that was positive at the time was respiratory syncytial virus. Day 3 and 4, patient was still intubated. She was in shock. At the time, COVID-2 was negative. ID consult was thinking about starting the antiretroviral therapy, but at this time, she was already started on pneumocystis and mycobacterial prophylaxis. She was on empiric hydroxychloroquine. Hepatology, we were consulted. She was negative for the acute viral hepatitis. And at the time, she had a blood-tinged nasogastric output, and therefore she underwent an endoscopy, given the SARS-CoV-2 was negative with full PPE precautions. and that showed gastric ulcers and duodenal ulcers. Pulmonary, she started having left lower lobe opacities and interstitial edema. The endotracheal secretions were sent, and she was positive for NGAL, which was consistent with invasive aspergillosis. MTB was negative. On day 4, again, for invasive aspergillosis, the ID started her on IV amphotericin, and the voriconazole and itraconazole being hepatotoxic were avoided. She was started on antiretroviral therapy with Truvada and dolutegravir, and all the rest of the medications were continued. Now, at this time, she already has ACLF grade 3, and she was not a candidate for transplant given the recent HIV diagnosis and very low CD4 count. And here is a list of all the ABGs that were drawn. You can see that she actually had severe acidosis, which got corrected with ventilator and CVVH management. Now, interestingly, the initial SARS-CoV-2, which was negative on day 1, actually turned out to be positive by day 4. Now, in the hospital course from day 5 to 11, she remains intubated. She was consistently in shock, and she was getting pressors. She was getting management for the acidosis, hypercarbonic respiratory failure, and she was on renal replacement therapy. For HIV and AIDS, the antiretroviral therapy was stopped on day 6 to prevent immune reconstitution syndrome. And for SARS-CoV-2, she also completed a course of hydroxychloroquine and Z-Pak between the days of 5 to 11. Now, fortunately, she didn't have any chloroquine-related sinus any arrhythmias, cardiac arrhythmias. Severe sepsis was presumed, however, blood cultures were negative ×3. Blood cultures were also negative for fungi and alpha and AFB. On day 10, she had profound hypotension, and ECMO was consulted, but it was contraindicated. Now, these were the chest x-rays, and you can see that from day 1, day 3, day 7, and day 11, a chest x-ray which was more or less normal actually turned to start having several infiltrates bilaterally, more so on the right side of the lung. Now, this is a graphic representation of all the ABGs, and you can see here that she was acidotic initially, and on day 7, she did have hypoxemia and severe acidosis, which again got more or less corrected with vent and CVVH management. Now, you can also see some of the inflammatory markers which were checked. IL-6, normal should be less than 5, which was profoundly elevated upon day 2, about 101. CRP, lactate, and ferritin, and even LDH, all the acute phase reactants were elevated throughout the course. Now, if you look at liver function tests in this patient, so she started with an AST, which is represented in the red graph. It was about 770, and by day 4 or 5, it started to improve, and she actually had less than 100 by day 11. ALT was also improved during the course, but alkaline phosphatase after day 7 started to go up and peaked at 532. Albumin, which is again one of the poor prognostic factors in COVID, remained between 2 to 3, which is represented by the red graph. INR, again due to a lot of corrections with FFP prior to endoscopy and dialysis catheter exchanges, improved to a certain extent and plateaued at around 1.5 by day 11. Bilirubin also followed the same trend. By day 6 or day 7, things were better, and by day 11, got slightly worse. So at this time, we're already dealing with a patient who has ACLF grade 3, and we know that the 28-day mortality in this patient is more than 75%. So to briefly touch about COVID-19 virology, I don't want to go in too much detail. It was the coronaviruses were first described in 1966 by Tyrrell and Bynoe. There are 4 subfamilies, and the SARS-CoV-2, which was previously called 2019 novel coronavirus, is a beta type coronavirus, and it has an incubation period of 5 days average. Now, it uses ACE2 receptor to get into the host cells, and we know that the ACE2 is the molecular target for SARS-CoV-2. which is predominantly expressed in the lung, but it's also expressed in several other tissues in the body. Now, in the liver, ACE2 is expressed in cholangiocytes predominantly, but a milder expression is seen in hepatocytes, and interestingly, there's no expression in Kupffer cells or endothelial cells. Now, this is a busy slide that shows a plethora of symptoms that COVID-19 can cause, and if you look at the pooled data, fever and cough are actually the top two symptoms associated with COVID. Now, the chronic medical illnesses, we know that hypertension and diabetes are the top two medical illnesses associated with severe COVID, but abnormal liver function in the pooled analysis does not appear to be posing a significant risk to these individuals. Now, the diagnostic tests, we know that lymphopenia is associated with poor prognosis in COVID. And again, there are all these routine blood work that we do upon admission. Now, if you look at the swabs that we do for ruling out COVID, the nasopharyngeal swabs, the non-PCR, the point of care swabs, there is a significant variability in the sensitivity of these tests. And actually, the sensitivity is highest for BAL or endotracheal secretions compared to the nasal or the nasopharyngeal swabs. And again, there are several other investigational tests which are being done to rule out COVID. Now, the AASLD has published its algorithm. So in a patient with COVID and elevated liver chemistries, like one in our patient, you need to consider ruling out other etiologies like the viral hepatitis. You need to review medications. And again, imaging typically is avoided unless it is going to change management. Now, during the course, if the liver tests are improving, we continue to monitor them closely. But if they're worsening, we need to evaluate for other causes. Especially if AST is elevated than ALT, it could be associated with viral myositis or ischemia or SIRS due to the cytokine release syndrome. And we need to keep in mind that all the medications that we use for COVID-19 can cause hepatotoxicity. These are some of the publications that we have. Typically, these are the initial literature available from China. So the first one shows that 115 COVID-19 patients were compared to those with community-acquired pneumonia. There were mild elevations in AST and ALT in both groups. INR is elevated. We know that COVID-19 can cause thrombotic and coagulopathic manifestations. So INR is elevated and CRP is elevated in COVID-19 patients. Older age, more than 60, and hypoalbuminemia are poor predictors for COVID. The other publication looked at 417 cases, and approximately 76% of them had abnormal liver tests, of which 21% developed abnormal LFTs after admission. So again, the authors concluded that this is most likely due to drug-induced liver injury versus severe pneumonia or sepsis. This is data from Columbia University. About 1,000 patients who are positive for COVID in New York were looked at, and a majority of them had mild elevations in AST and ALT, but significant elevations more than 5 times is really rare in patients who were tested for COVID. There is also emerging data in liver biopsy, typically after postmortem. The autopsy results showed that most patients actually tend to have microvesicular steatosis. Inflammation typically tends to be mild, lymphocytic, and focal. And again, in some of the cases, sinusoidal congestion, which is typically associated with positive pressure ventilation, was found to be positive in most liver biopsies that were published. This is a pooled analysis of all the papers that were published who had abnormal liver tests in COVID-19. And again, you can see that the range can be anywhere between 28 to a maximum 53% of patients who can have abnormal liver tests. In this paper, there was no incidence of abnormal liver tests which was any different between survivors and non-survivors. And again, the authors basically concluded, you can look at the heading, that chronic liver disease is not associated with severity or mortality in COVID-19. Now, COVID-19 has also caused a lot of changes in practice, and this is recommended by the AASLD Clinical Insights. So in the pre-transplant setting, a patient who is positive for hepatitis B would continue treatment. Patients who require direct-acting antiviral therapy for hepatitis C can be delayed. Immunosuppression should be continued in autoimmune hepatitis, but if there is a flare, we need to avoid high-dose steroids. Endoscopy can be delayed in most elective cases, but in urgent cases, full PPE is required. HCC screening and surveillance, the scans can be delayed approximately up to 2 months, but really in a patient who has HCC, local regional therapy or TACE, these are ideally not delayed. We know across the globe that the liver transplant organ recovery is quite low, and for this reason, high MELD patients should be prioritized. All donors and recipients are screened for COVID-19, and typically if they're positive, they're not a candidate for transplant. However, in recipients who actually present with acute liver failure, we need to keep in mind how they present. If they have ARDS, and depending on the age and functional status, it is a case-by-case evaluation that can be done in these patients. In post-transplant setting, immunosuppression is not a risk factor. We know that these lessons are learned from SARS in 2003 and from MERS in 2012. So therefore, no reduction empirically is required for immunosuppression. Steroids are okay to be given in the setting of acute rejection. And again, a couple of points for the hepatology practice is liver biopsy is necessary only if it changes management, like in the flare of autoimmune hepatitis or acute cellular rejection. We also need to keep in mind that immunosuppression prolongs viral shredding, so these patients can be carriers for a longer time. Now, this is a list of all the medications and therapeutic targets, which I'm not going to go into, but it is presented for the syllabus. Now, when we look at the causes of liver dysfunction in a patient with COVID-19, it can be because of direct viral cytotoxicity, or indirectly because of SIRS or immune-mediated. But in predominant cases, if we see more than 5 times, we need to keep in mind that anoxia and ischemia or hypotension is the most likely cause. Passive congestion from positive pressure ventilation is coming to be positive in most of the biopsy slides and histology literature. Drug-induced liver injury should definitely be kept in mind. Chloroquine, antiretroviral therapies, and also antivirals in clinical trials are associated with drug-induced liver injury. We need to keep in mind about acute and chronic liver failure, and especially hepatitis B reactivation when using tocilizumab or other biologics. And again, when AST is higher than ALT, myositis and extrahepatic organ injury should be kept in mind. So there are several pitfalls in the diagnostic tests as well. It depends on where it was obtained. So here you can see that majority of the bronchoalveolar lavage specimens were positive, but if you take nasal or pharyngeal swabs, the sensitivity actually goes down. It also depends on when the test was done. So in the initial first week, the test is positive, but as you go longer and far away from the time of the symptoms, the sensitivity actually drops down. There's a nice paper in radiology which actually showed that CT chest actually has a higher sensitivity compared to RT-PCR, 88% versus 59%. And again, CT findings were positive even when the initial RT-PCR was negative. So again, something to keep in mind, although we're not subjecting a lot of the COVID positive patients for CT chests. And this is again to show that there are more than 28 tests, including the saliva and the finger prick test, which are not even included in this paper, which are all approved for emergency use authorization. We need to keep in mind about the false positive and false negatives and how it impacts public health. So back to our patient, she expired on day 11. So the questions really are, did she die from COVID-19 or did she die with COVID-19? Now it's debatable and most likely an autopsy would prove it. But we need to keep in mind that in HIV/AIDS and invasive aspergillosis, there is a very high ICU mortality, especially in those with CD4 less than 100. ACL of grade 3 is associated with more than 75% mortality in 28 days. So again, there are these interesting headlines from various newspapers which deaths count towards COVID-19. Are COVID-19 deaths inflated? So again, if a patient dies of a heart disease, for example, and he was found to be an asymptomatic carrier of COVID-19, the medical examiner can legally associate the death to the COVID-19 death toll. The next question is really COVID-19 is a culprit or a bystander in her liver injury. So if you follow the liver enzymes graph, the AST and ALT significantly improved. INR and bilirubin more or less stabilized. So causes like ischemia, myositis, congestion, drug-induced liver injury are out of question. Direct viral cytotoxicity is also out of question because, again, we know that liver function tests are rarely over 3 to 5 times the upper limit of normal. And therefore, most likely in this patient, the cause of ACLF is acute alcoholic hepatitis, which was actually compounded by multi-organ failure from severe sepsis and SIRS. So few take-home messages. ACLF has poor prognosis compared to acute decompensation. We know that ACE2 expression is present in ileum, colon, and cholangiocytes. Abnormal liver tests can be seen in 25 to 76% of COVID-19 patients. However, significant elevation is quite rare, and if present, we need to think about alternate causes. And typically those alternate causes are SIRS, ischemia, anoxia, drug-induced liver injury, or congestion. We know that underlying risk factors for NAFLD, like hypertension, diabetes, coronary artery disease, and obesity, increase the risk of COVID-19 severity, but what we don't know is whether fatty liver itself is a risk factor for COVID severity. Immunosuppressed and transplant recipients can carry the disease for a longer term. They're still at risk and they need to be closely monitored. So this is my last slide. So really, we have a huge reality shift and we are now in a new normal state. We need to also shift our learning from crisis to cautious mode. There are more than 5,000 publications on COVID-19 in PubMed and more than 80 in NEJM. Initial reports of children and transplant recipients being protected is actually not true. So therefore, we need to keep in mind the perils of non-peer-reviewed science in the times of pandemic. And again, a second wave is possible upon reopening the Spanish flu. So again, as we commemorate the 50th anniversary of Apollo 13, all that we know about COVID-19 and all the reasons behind reopening, I just hope that reopening will not be labeled as a successful failure. I thank you all for your attention.
Thank you, Ram. That was a great, timely, and very clear presentation. We all appreciate it. If anyone has a question, you can either raise your hand or chime in. I think your notes of caution are important. I guess the issue is there anything, one of the many issues that you bring up, is there anything to be learned from other patients that have cytokine storm and their liver function abnormalities that might differentiate the COVID or the SARS-CoV-2 viral infection from that?
Yeah, so initially the thought was most of the liver dysfunction that we're going to see was probably due to the cytokine storm or SIRS or immune mediated. But according to most of the reports that we saw from the Chinese and now more importantly emerging from New York, it's typically related to not just the cytokine, but also the patient has to be hemodynamically unstable. Now, liver function tests more than 5 times just because of COVID-19 is unlikely. But again, if you're seeing hypotension, if you're seeing other organ dysfunction, that actually contributes to a significant elevation in the liver enzymes.
And of course, the use of
and definitely antiretrovirals and the medications that we're using in this pandemic, need to be kept in mind.
Yeah, but if somebody has disseminated aspergillosis, right, you wonder how you might not want to further immunocompromise them. Well,
Yeah.
that was
Our focus has always been in COVID-19 in the last couple of months, but again, we need to focus that these patients are at risk for other conditions, and those other conditions need to be systematically ruled out.
Thank you very much. That was a great presentation.
Thank you.
Okay, we'll go to our next presenter.
All right, our next presentation will be delivered by Dr. Ozlem Pala, who will talk to us about the updates in rheumatology. Dr. Pala is an assistant professor of clinical medicine in the Division of Rheumatology. She completed her residency at Englewood Hospital and Medical Center, followed by rheumatology fellowship at Albany Medical Center. She has a special interest in rheumatoid arthritis, publishing articles related to cardiovascular morbidity in RA, as well as the impact of TNF-alpha inhibitors on B lymphocytes in these patients. Thank you for joining us today, Dr. Pala. I'll pass it over to you.
Hello, good afternoon, everyone. Thank you for the introduction and also inviting me to present at the Grand Round. So today I will present updates in rheumatology. So let me share my screen. I apologize. Just bear with me for a moment.
It's the one all the way to your right, Dr. Pala.
Yes, all right, thank you.
You're welcome.
All right, well, first of all, I have no conflict of interest to declare related to this presentation. And during this presentation, I will cover multiple topics to provide an overview in some of the rheumatic diseases and recent updates. Due to limited time, only selected topics are included. So we will discuss systemic lupus erythematosus, ankylosing spondylitis, osteoarthritis, Behçet syndrome, and rheumatological complications of checkpoint inhibitors. So now let's talk about systemic lupus erythematosus. It is also known as SLE. So SLE is a chronic autoimmune disease of unknown cause that could affect virtually any organ of the body. So some of the most common manifestations are, as shown here, include malar rash, also known as butterfly rash, oral ulcers, arthritis, cardiovascular involvement such as pericarditis or endocarditis, Raynaud phenomenon, and renal involvement. So in 2019, European League Against Rheumatism and American College of Rheumatology classification criteria for systemic lupus erythematosus was published. So presence of positive antibody, anti-nuclear antibody is required as an entry criterion. And additive criteria consist of 7 clinical and 3 immunological criteria categories. So patients with score of 10 or more points are classified as having SLE. So this slide will allow me to better explain it. ANA at 1 to 80 is required as an entry criterion. So ANA at 1 to 40 has no clinical significance and therefore does not require further testing. If ANA positivity is present, then we can apply additive criteria. However, before that, we have to remember a few points. So you do not count a criterion if there is a more likely explanation than SLE. An occurrence of criterion on at least one occasion is sufficient. For example, if we can see a documentation of thrombocytopenia in the past, then we can count it even if it is not present at the time of most recent evaluation. And criteria does not need to occur simultaneously. Within each domain, only the highest weighted criterion is counted toward total score. So now, as you can see in the clinical domains, we have constitutional, like fever, we have hematological manifestations like leukopenia, thrombocytopenia, autoimmune hemolysis. In neuropsychiatric domain, we have delirium, psychosis, seizure, mucocutaneous, non-scarring alopecia, oral ulcers, subacute cutaneous or discoid lupus, or acute cutaneous lupus. In serosal clinical domain, pleural or pericardial effusion, acute pericarditis, musculoskeletal with joint involvement and renal involvement. And immunology domains, we have antiphospholipid antibodies, complement proteins, and SLE-specific antibodies. So let me give you one practical example here to make it more clear. So assume that our patient has ANA and a titer of 1 to 160. So this patient would meet entry criterion, and if there is no other possible explanation, then we would move on to assess for clinical symptoms. So if patient has any of the clinical symptoms, then we would determine to see which one they are and count them toward the total points. So let's say patient has both leukopenia and thrombocytopenia, then patient would only get 4 points from the highest weighted one. And let's also say patient has oral ulcers, she gets 2 more points. And if you look at the immunology domain, if patient has presence of double-stranded DNA antibody, then it would count as 6 points, and total point would be 12, so it will be more than 10, and diagnosis of SLE can be made. So current treatment options for SLE includes glucocorticoids, anti-malarial agents like hydroxychloroquine, methotrexate, mycophenolate, azathioprine, cyclophosphamide, and cyclosporin. Rituximab can also be used in selected patients. Belimumab is a human monoclonal antibody that inhibits the soluble form of B-cell survival factor, also known as BILIS. Belimumab actually may work well for active musculoskeletal or cutaneous disease that is unresponsive to standard therapy with glucocorticoids or other immunosuppressive agents. It was first approved by FDA in 2011, and that's really the first targeted therapy for lupus. So trial of anifrolumab for systemic lupus erythematosus is published in New England Journal of Medicine this year. Phase 3 trial of 362 patients with SLE. Anifrolumab is a monoclonal antibody against type 1 interferon receptor. It improved clinical response rates, glucocorticoid requirements, and skin disease severity compared with placebo at 1 year. No effect on swollen and tender joint counts, and the annualized flare rate were actually seen. So the next slide will provide us some more details of the study. It's a multi-center, randomized, double-blinded phase 3 trial of 362 patients with SLE. Anifrolumab 300 milligram every 4 weeks was given for 48 weeks versus placebo. And response rate at 52 weeks was assessed by using composite index called British Isles Composite Lupus Assessment. 47.8% responded in treatment arm versus 31.5% in placebo arm, and difference is 16.3%. So this is an exciting development since we have very limited treatment options for SLE. Now in the next slide, I would like to discuss ankylosing spondylitis. Picture on the left is a very classic picture. It illustrates progressive deformity due to ankylosing spondylitis over a period of 36 years. And the other picture on the right also illustrates progression of ankylosing spondylitis if it is not treated effectively. So non-steroidal anti-inflammatories are initial treatment of choice in ankylosing spondylitis. Approximately 70 to 80% of ankylosing spondylitis patients report substantial relief of their symptoms, including back pain and stiffness with anti-inflammatories. After 2 different anti-inflammatories used for 2 to 4 weeks, if there is no adequate response, then we initiate TNF-alpha inhibitor therapy. In patients who have contraindications to use TNF inhibitors, then we suggest treatment with anti-IL-17 antibody, secukinumab or axekizumab. In this slide, I will provide an overview of JAK inhibitors. They are actually being studied as a potential treatment option in ankylosing spondylitis. There are currently 3 agents. One is tofacitinib, the second one is baricitinib, and the last one is upadacitinib. They're all approved for rheumatoid arthritis treatment, and tofacitinib actually is approved for psoriatic arthritis treatment. They are oral agents with quick onset of action, effective as monotherapy or in combination with other non-biologic DMARDS. Potential side effects include anemia, neutropenia, lipid elevations, LFT elevations, and increased risk of thrombosis. So the newer agent, upadacitinib, is a Janus kinase JAK inhibitor with preferential effects on JAK1 is being evaluated in Select Access 1 trial, and results were published in Lancet late last year. This was a multicenter, randomized, double-blind, placebo-controlled phase 2/3 trial. Nearly 200 patients with active ankylosing spondylitis who had an inadequate responses or intolerance to non-steroidal anti-inflammatories were included. A composite clinical response at 14 weeks was more frequent with trial medication versus placebo, 52% versus 26%. Improvement in function and in axial inflammation on MRI were also seen. No serious infections, herpes zoster, malignancy, venous thromboembolic events or deaths were reported, and only 1 serious adverse event was reported in each group. So now we'll move on to osteoarthritis, potential osteoarthritis treatment. So as you know, there are currently no disease-modifying osteoarthritis medications approved for use. Ciprofirmin, which is a recombinant human fibroblast growth factor 18, has been studied, and it's been shown that it may increase cartilage thickness, reduce cartilage loss in knee osteoarthritis. So primary results from forward study combined with findings from the post-hoc analysis suggest that it should be evaluated for further use in clinical trials as a potential disease-modifying agent for knee osteoarthritis that can substantially reduce cartilage loss. This is a quite exciting study, since we really have no effective therapies to offer our patients with osteoarthritis. Hopefully we will have better therapies in the near future, since osteoarthritis is really the most common type of arthritis. In the next few slides, I will discuss Behçet Syndrome very briefly and new treatment option for one of its most important manifestations. Behçet Syndrome is characterized by recurrent oral aphtha and any of several systemic manifestations, including genital aphtha, ocular disease, skin lesions, gastrointestinal involvement, neurological disease, vascular disease, or arthritis. It is more common along the ancient Silk Road. It is very remarkable for its ability to involve blood vessels of all sizes, small, medium, and large, and on both the arterial and venous sides of the circulation. Topical or systemic glucocorticoids, also colchicine, has been used for treatment of oral and genital ulcers in the past. And trial of apremilast for oral ulcers in Behçet syndrome was published in New England Journal of Medicine late 2019. Apremilast is an oral phosphodiesterase 4 inhibitor. and it resulted in greater reduction in number of oral ulcers after 12 weeks, with continuation of this benefit up to 28 weeks. It is now FDA approved for treatment of oral ulcers in Behçet Syndrome. In this slide, you can see the details of the study. It is a phase 3 double-blind randomized trial, including 207 patients. Half of them were randomized to receive apremilast 30 milligram twice daily. Another half received placebo. The primary endpoint was the area under the curve for the total number of oral ulcers during 12-week placebo control period, and with lower values indicating fewer ulcers. The area under the curve for the number of ulcers was 129.5 for apremilast as compared with 222.1 for placebo. So apremilast actually resulted in greater reduction in the number of oral ulcers than placebo, but was associated with some adverse events such as diarrhea, nausea, and headache. In the next 2 slides, I will briefly cover rheumatological complications of checkpoint inhibitor immunotherapy. Immune checkpoint inhibitors are the most commonly used type of cancer immunotherapy, but can cause a number of immune-related adverse events. Metastatic melanoma, non-small cell lung cancer, renal cell carcinoma, Hodgkin lymphoma are some of the cancers that this group of medications are used currently. Most common symptom that we see is arthralgia, which is non-specific, only joint pain with no evidence of inflammation. And that's been described in approximately 10 to 15% of patients. And this is closely followed by myalgia and Zika complex, dryness of the eyes and mouth. So development of symptoms of an actual inflammatory systemic autoimmune disease, such as inflammatory arthritis with presence of synovitis, myositis, Sjogren's syndrome, or vasculitis is much less common. And according to literature, frequency is anywhere from 3.5 to 6% of patients treated with checkpoint inhibitors. So inflammatory arthritis is the most commonly reported adverse event. Initial treatment is with non-steroidal anti-inflammatory or low-dose glucocorticoids. Severe arthritis may require higher dose of steroids. In patients with mild to moderate but persistent inflammatory arthritis who cannot be weaned off steroids or tapered down to lower dose than conventional synthetic DMARDS such as sulfasalazine, hydroxychloroquine, or methotrexate can be used. And in severe cases, anti-TNF agents or tocilizumab have been actually used successfully. So in conclusions, in recent years, there have been great advances in treatment of most rheumatological conditions. Early and accurate diagnosis followed by effective treatment can slow down or prevent disease progression in most patients with rheumatic diseases. And there are many new treatment options being developed, studied, and are likely to be available in the near future. This concludes my presentation, and I welcome any questions.
Thank you, Dr. Palla, for presenting a very thorough and relevant updated view on the various rheumatologic diseases and new therapies. One question that I might have at this point is, and we'll wait for others to ask as well, is whether or not with the immune checkpoint inhibitors, whether the rheumatologic manifestations are actually a good prognostic sign for the use of those agents in the treatment of the cancer. In other words, it's been shown, for example, in the autoimmune components of thyroid disease, that actually is an indicator that the cancer is more likely to respond if there's such a side effect. Has that been shown in the rheumatologic literature?
Thank you for the question, Dr. Weiss. It's a very interesting topic, and it's really evolving. We don't really have much literature. I recently seen a publication about using biologics for treatment of immune-mediated complications and see if that has any effect on cancer prognosis or any effect on survival. And I believe there was no really any downside of using therapies if necessary. That's the only new information I have available on this. But it's an evolving, very interesting topic, really, with the use of those medications.
There's a question on the chat I'll read. Can syncope be considered part of the neuropsychiatric picture of lupus?
Sorry, let me check. So actually, no, it is not listed as a part of the psychiatric picture of lupus. You know, syncope is very non-specific symptom. It could be mostly cardiovascular or other causes, but patients should really have an appropriate workup. I don't think having syncope by itself without other clinical features would necessitate really checking patients with lupus, because ANA is a really very commonly ordered test, and sometimes we really feel that it's unnecessary to check ANA for every patient. So my quick answer would be no. I would go with more common causes of syncope before I would consider lupus as a cause.
Dr. Mendoza asks your thoughts on the use of topical analgesics such as Voltaren and Capsin for in the use of osteoarthritis.
That is an excellent question. I actually very commonly use topical medications when I treat osteoarthritis. As I said, we have very limited options, and typically we see osteoarthritis in older patients. So we have to be very careful when we use non-steroidal anti-inflammatories. There are a lot of limitations when we use them orally. So I often use topical arthritis, not to exceed 3 grams, and typically diclofenac gel, Voltaren gel, to treat knee arthritis or hand arthritis, which is approved for those uses. And good news is, after many years, actually Voltaren is just approved to be over the counter in the United States. So we're expecting this medication to be available on the shelf very soon. It's been available in other countries for many years without prescription, and finally we have it available for patients without prescription. And for the capsaicin, it is a hot pepper extract. There has been some studies in the past to show that it could be beneficial. It's very limited, but if there are no other options, actually capsaicin definitely can be offered, especially for superficial joints like hand joints, CMC, carpometacarpal joint arthritis, or perhaps for the knee arthritis. It could be definitely used. I didn't mention, but actually there is some emerging evidence that turmeric might be helpful treating osteoarthritis and rheumatoid arthritis pain. So a lot of people, especially older people, when we have a lot of limitations treating them with non-steroidal anti-inflammatories, we can use natural supplements like turmeric to alleviate some of the pain.
Very good. Seeing no further questions, I want to thank both our speakers and look forward to seeing you all next week. Please be safe, and thank you for everything that you do. Have a nice day.
Thank you.